Welcome to Module 2 of the ABC Compliance video series. In this module, we'll focus on the importance of consistently identifying the primary mode of anesthesia. This topic has been the subject of much debate in recent years. After listening to this discussion, you may choose to bring it to your entire practice to ensure that all providers are on the same page. In this session, we will explore 5 key issues with regard to the primary mode of anesthesia. We'll identify the modes of anesthesia that are critical to billing and claim submission. Since the ASA has revised its definition of general anesthesia, many practices find that there are very few MAC cases anymore. CMS has very specific guidelines for the submission of MAC claims. Depending where you live, your intermediary may have special billing instructions. The dramatic growth of anesthesia charges for endoscopic cases has had some significant repercussions. It's important to know how these might impact your practice. And finally, there are now new codes for endoscopy cases. It's important that your documentation supports the specific requirements of these new codes. Let's be clear about one thing as we begin this discussion. From a billing perspective, there are only 3 modes of anesthesia that matter. To generate a claim, every case must be classified as either a general, a regional, or a MAC anesthetic. Documentation of the primary mode of anesthesia for each case is critical for accurate billing, as the mode of anesthesia determines which of a number of billing algorithms is applicable. From a clinical perspective, you may want to describe the mode of anesthesia in some detail, but from a billing perspective, there are only 4 that matter: general, MAC, regional, or local. Since general anesthesia is the most common, we want to make sure we understand what constitutes a general anesthetic. A general anesthetic occurs when the patient is unarousable, even with painful stimulants. For purposes of billing, there must be consistency in the designation of the primary mode of anesthesia. If the case is marked as a general anesthetic, for example, and there is an interscalene block, then the block may be separately billable. If the case is marked as a regional anesthetic, however, then the block will be considered the primary mode of anesthesia and not billed separately. A MAC case is one in which the patient may be sedated, but who is nonetheless arousable. It may be easier to think of it this way: any case that is not a general or a regional is a MAC. Some prefer to consider cataracts as MAC cases, although this is not the norm. But endoscopic cases involving propofol should be marked as general anesthetics. The Center for Medicare and Medicaid Services and some other payers require that all claims that are MAC anesthesia must be flagged with a QS modifier. Certain Medicare localities may have local carrier determinations, referred to as LCDs, and these could impact payment. In other words, the anesthesia provider must indicate both the surgical diagnosis and the reason a separate payment needs to be made for an anesthesia provider. The dramatic growth in endoscopic anesthesia over the past couple of decades has caused many payers to question the need to pay for the anesthetic management of the case. There was a point in time when a major insurer refused to pay for anesthesia services for ASA 1 and 2 patients who had endoscopic surgery. It did not take long for the insurer to rescind its policy because it became quite clear that patients were much more likely to undergo a colonoscopy if they had anesthesia. For a long time, there was a question in the community as to whether other payers would stop paying for anesthesia for these cases. Finally, a few years ago, as a result of the provisions of the Affordable Care Act, the ACA, the issue was put to bed. Under the ACA provisions, if the case is booked as a screening colonoscopy and nothing is found, then the patient has no responsibility for deductible or copayment. If the case is booked as a screening colonoscopy and a polyp is removed, then the deductible is waived, but the patient must still pay the copayment. Not to worry though, the payment to the anesthesia provider is still the same. If the case is scheduled for a specific patient condition, then all bets are off and the patient pays the deductible and copayment. There's no evidence that other payers have implemented similar policies with regard to the patient responsibility for deductible and copayment. The net result, however, was a global recognition that paying for anesthesia for colonoscopies ultimately saves money. Many practices across the country continue to view anesthesia for endoscopy as the fastest growing and most profitable line of business. The average ABC client east of the Mississippi generates 25% of its total revenue from endoscopic procedures, while those in the West collect considerably less than that from endo cases. But the West is catching up fast. Last year, the codes for endoscopic services were modified. There were only 2 ASA codes for endoscopy, 00740 for upper GI procedures and 00810 for lower GI services. All cases were worth 5 base value units. The new codes have increased the value for ERCP procedures and lowered the value for lower GI procedures. The primary focus of the revision was colonoscopies. Medicare has devalued these procedures from 5 to 3. Other payers are typically paying for them now based on a base value of 4 as per the 2018 ASA Relative Value Guide. Don't worry about having to learn or memorize these 5 new codes. The takeaway here is that the documentation must clearly designate whether the procedure involved upper or lower endoscopy or combined service. For colonoscopies, 2 diagnoses are required to indicate why the procedure was performed and what the outcome was. Regional anesthesia should be noted when the case only involves an epidural, spinal, or neuraxial block and the patient remains conscious. Please make sure to note the case as a general if it converts from a regional to a general. Also, do not confuse the use of a nerve block as the primary mode of anesthesia, which would make it a regional, with the use of a nerve block for purposes of postoperative pain management, which would be a general anesthetic. A final note about the mode of anesthesia. Many clients struggle with the notion that so many cases once listed as MAC are actually generals. They worry about the disparity between the way a case may be booked by the surgeon and the mode of anesthesia marked on the anesthesia record. The fact is that the designation of the primary mode of anesthesia is a very arcane aspect of claims processing. Because it is revenue neutral, it has no impact on claims processing except mentioned above. No one except those involved in claims processing even pays attention. If you have questions about these distinctions and how they may apply to your practice, or if you are unsure about the specific payer rules in your region, feel free to contact your ABC account manager or the ABC coding department. Thank you for participating in this ABC compliance program. We hope the information presented here is useful to you in understanding the requirements of compliant billing. We greatly value your comments and feedback on this program. For more information, feel free to write to jody.lock@anesthesiallc.com or even to call 619-249-9801. Please pass along any comments or questions you may have to the ABC Compliance Department at compliancehelp@anesthesiallc.com.